Welcome to the Rad-On Smart Review Head and Neck Cancer series. I'm your host, and I'm ready to get back into the weeds with you.
It's great to be back.
We are tackling episode 23 today, Nasopharynx 3, Induction and Concurrent Systemic Therapy.
Right.
If you were with us for episode 22, we established that NPC is effectively a different species compared to other head and neck cancers.
It really is. It's radiation-driven. The anatomy is tricky.
And the EBV biology changes everything. Then in 22B, we mapped out the target volumes. But today
we are talking about the engine of the treatment plan. Okay. This is the make or break part of the discussion. We're getting into the systemic therapy backbone.
And this is what really determines whether your patient gets a cure or develops distant metastases down the line.
Exactly. This is the decision-making process.
And I want to flag something right at the top. This is an incredibly high-yield topic because NPC systemic therapy, well, it breaks all the rules we learned for other sites.
It really does.
We have this dogma in head and neck oncology, mostly from the oropharynx and larynx data, that induction chemotherapy is a failed experiment.
Right. We all saw the trials fail. We saw the toxicity.
But here is the hook for today. Those induction studies that failed for, say, the larynx.
They actually work for NPC.
And understanding why that's true is the key to answering your board questions correctly and, frankly, saving your patients from distant failure.
That's the whole point. By the end of this, we want you to know INT 0099 cold.
We want you to understand the MAC-NPC meta-analysis hierarchy so well you can draw it.
And we want you to be able to defend induction chemotherapy for bulky disease with total confidence.
We're also going to give you clear triggers for when to use induction versus adjuvant sequencing, which is, it's a constant source of confusion.
It is.
Let's get started by anchoring this in a clinical reality. We need a patient to treat.
Okay, let's look at a classic presentation. We have a 48-year-old Vietnamese man. He presents with a 2-month history of bilateral neck masses and some nasal obstruction. He has a 10-pack-year smoking history, but he quit 15 years ago.
So relatively young endemic demographic. What are we feeling on the exam?
Palpation reveals a 4-centimeter left level 2 node and a 2.5-centimeter right level 2 node.
Okay.
When you do your nasopharyngoscopy, you see a mass involving the left fossa of Rosenmuller, and it's extending across the midline.
Standard so far. Let's talk imaging.
The MRI shows a 3.5-centimeter primary tumor. Crucially, there's skull base erosion involving the clivus and bilateral parapharyngeal extension. It confirms that bilateral level 2 adenopathy you felt.
And the cavernous sinus?
No cavernous sinus invasion. The PET-CT confirms the FTG, avid primary, and bilateral nodes, but, and this is critical, no distant metastases.
And the pathology report, what does that say?
Biopsy comes back as non-keratinizing undifferentiated carcinoma, WHO type 3. It's EBV encoded RNA positive. We check his plasma, EBVDNA, and it is markedly elevated at 25,000 copies per milliliter.
Wow. Okay, let's stage him.
So with all that, we're looking at T3, N2, M0, stage 3 by AJCC 8th edition.
So here is the moment of truth. The medical oncologist turns to you and asks the clinical question.
A big one.
Should we give induction chemotherapy before chemoradiation or proceed directly to concurrent chemo-RT with adjuvant chemotherapy afterward?
That is the million-dollar question. And frankly, depending on when you trained, you might answer that very differently.
Before we unpack the data, I want you to give us the model 60-second board answer. You're in the hot seat. The examiner is staring at you. How do you handle this?
Ideally, I would answer like this. This is a 48-year-old man with T3N2M0 nasopharyngeal carcinoma, non-keratinizing undifferentiated histology WHO type 3, EBV positive with markedly elevated plasma, EBV-DNA at 25,000 copies per milliliter. He has bulky bilateral nodal disease, placing him at high risk for distant metastasis. For this patient, I would recommend induction chemotherapy with gemcitabine and cisplatin for 3 cycles, followed by concurrent chemoradiation with high-dose cisplatin. This approach is supported by the Zhang NEJM 2019 trial, where the final OS analysis showed a 5-year overall survival improvement from approximately 79% to 88%. Furthermore, the MAC-NPC meta-analysis demonstrates that induction provides superior distant metastasis control, which is this patient's primary risk. The alternative CCRT, followed by adjuvant chemotherapy per INT 0099, is also Category 1. However, the evidence for routine adjuvant after CCRT is mixed, and completion rates are notoriously poor, often 50 to 60%.
Induction delivers chemotherapy up front when patients can best tolerate it. I would also monitor EBV-DNA kinetics during induction, as a response biomarker.
That was excellent. Precise, evidence-based, and you were decisive. You acknowledged the alternative, but you really justified your choice based on the specific risks of this patient.
Right.
Now let's peel back the layers. Every conversation about NPC systemic therapy really begins with one trial.
It has to. INT0099, also known as the Al-Saraf trial. This was published in JCO way back in 1998.
And this is the landmark that effectively killed radiation alone as a standard for advanced disease.
It did.
Walk us through the design, because the details, they really matter for the critique later on.
Okay, so they took 147 patients with stage 3 to 4 NPC. This was based on the AJCC 4th edition.
Right.
Now, keep in mind, due to staging drift, some of those patients, specifically the node-negative ones, would be stage 2 today.
Oh, okay.
They randomized them to radiation therapy alone to 70 gray versus radiation plus concurrent cisplatin.
That was the high dose, right?
Yes, 100 milligrams per meter squared every 3 weeks for 3 cycles.
And that wasn't all. The experimental arm had a tail.
Correct. The experimental arm also included adjuvant chemotherapy. It was cisplatin, 80 milligrams per meter squared, plus 5 FU.
That's a continuous infusion.
Right, 1,000 milligrams per meter squared, continuous infusion for 96 hours. This was given every 4 weeks for 3 cycles.
So the plan was a total of 6 chemotherapy cycles, 3 concurrent, 3 adjuvant.
That was the plan.
And the results were just massive.
Massive is the right word. The 3-year overall survival went from 47% with radiation alone to 78% with the combined approach.
That's a 31% absolute improvement.
It is. The trial was actually stopped early because the survival advantage was so significant.
So the board soundbite here is...
INT0099 showed a 31% absolute improvement in 3-year overall survival, the largest survival benefit demonstrated in any head and neck cancer trial.
However, for board exams and, for clinical practice, we need to be able to critically appraise this trial.
Oh, absolutely.
It wasn't perfect, and honestly, if you tried to run this exact protocol today on an endemic population, you might get some side-eye. What are the main criticisms?
There are 4 big ones you need to know. First, the population concerns.
Okay.
Only 41% of the patients were WHO type 3, which is the endemic type we see in Asian populations.
So not representative.
Not entirely.
Yeah.
They had 25% WHO type 1 or keratinizing type. This is significant because keratinizing NPC behaves more like standard squamous cell carcinoma.
Worse local control, fewer distant mets.
Exactly. So people argued this study wasn't fully representative of the patients we worry about most.
And the second critique.
Completion rates. They were poor.
How poor?
Only 63% of patients completed all 3 concurrent cycles, and only 55% completed all 3 adjuvant cycles.
That is a crucial point. Nearly half the patients didn't get the full treatment as it was designed.
Right.
It makes you wonder, was the benefit from the concurrent part or the adjuvant part, or both?
Exactly. And that ambiguity, it fueled 20 years of subsequent trials.
Okay, what was number 3?
Third, this was the pre-IMRT era. They used 3D-CRT. Modern techniques achieve better local control with less toxicity, so the absolute benefit of chemo might be different now.
Fair point. And the last one.
And fourth, as I mentioned, there's staging drift. The 4th edition staging included N1 patients that we might classify differently now.
Okay, so despite those flaws, INT0099 changed the world. But we needed to know if it worked in endemic populations. That brings us to SQNP01.
Right, this was the WE trial out of Singapore, published in JCO in 2005.
And they used the same regimen?
The same Al-Saraf regimen, but in 221 patients with stage 3 to 4B, and crucially, 100% were WHO type 2 or 3.
So a true endemic population. Did it hold up?
It did. They confirmed the results. 2-year overall survival improved from 77% to 85%.
What about distant
Distant metastasis rates dropped from 30% to 13%. It really proved that the benefit seen in Al-Saraf wasn't just a fluke.
So it wasn't just because the radiation alone arm did poorly or because of the histology mix?
Correct. It represents a true biologic effect in endemic NPC.
Okay, so we've established that concurrent chemoradiation is the standard backbone, but now we have much more data specifically regarding that adjuvant tail versus induction.
Right.
Let's talk about the evidence hierarchy and the MAC-NPC meta-analysis. This is really the source of truth for modern decision-making.
The MAC-NPC meta-analysis, updated by Blanchard in 2022, synthesizes 26 trials, in over 7,000 patients. This is big data.
Huge.
If you remember nothing else, remember these findings. First, concurrent chemotherapy is the essential backbone. You can't skip it.
And what's the benefit there?
It gives a 5-year overall survival benefit of plus 5.2%.
Okay. Can't skip concurrent, but the sequencing matters.
It does. When you look at concurrent plus adjuvant, you see the largest overall survival benefit in the pooled analysis, plus 12.3% at 5 years.
That's a big number.
It is. The hazard ratio for distant metastasis is 0.65.
Okay, so that sounds like adjuvant is the winner.
Hold on. When you look at induction plus concurrent, you see the best distant metastasis control with a hazard ratio of 0.63. The overall survival benefit is also robust at plus 6%.
So let me clarify this. Concurrent plus adjuvant has the best pooled overall survival stats historically, but induction plus concurrent is the king of distant control.
Correct. And you have to remember, the concurrent plus adjuvant data is heavily weighted by those older trials like INT0099.
Where the control arm alone performed very poorly.
Exactly. The induction data is generally more modern, comparing against much stronger concurrent chemoradiation controls.
What about using just adjuvant or just induction by itself?
The meta-analysis was clear. Adjuvant alone, or induction alone, without the concurrent component, does not improve overall survival. You need that concurrent backbone.
Good to know.
Also, there's a significant age effect. The benefit of adding chemotherapy decreases as patients get older.
How much?
If you're under 40, the benefit is huge, 8.5%. If you're over 60, it drops to 3.9%.
That aligns with what we see clinically. Younger patients tolerate it better and have more aggressive biology.
Right.
So the board's safe statement here is that the choice between adding induction versus adjuvant depends on the clinical scenario. If you need maximum distant control,
You lean toward induction. Precisely.
This leads us naturally into the induction debate. I feel like residents get pimping questions on this all the time. An attending says, induction doesn't work in head and neck cancer. Look at the paradigm and decide trials. Why is NPC different?
It is the exception that proves the rule. In oropharynx and larynx, the paradigm and decide trials tested induction TPF.
That's docetaxel, cisplatin, fluorouracil.
Right. They followed it with chemoradiation and found no survival benefit, just more toxicity.
Yeah.
But NPC is different for several reasons.
Give us the list.
Number one is the high baseline distant metastasis risk. In advanced stages of NPC, you have a 20 to 30% distant failure rate.
So just more micrometastatic disease to control from the start.
Exactly. Way more than a T3 larynx cancer, which usually fails locally.
And as we just said, the MAC-NPC data shows induction specifically hits that distant risk.
Right. Reason number two is that MAC-NPC proves that distant metastasis benefit is unique to this histology.
Okay, what else?
Reason number three is logistical, but is very real. Adherence. Patients tolerating chemotherapy much better before radiation than after.
That makes sense.
Adjuvant completion rates are notoriously poor because patients are exhausted, malnourished, they have mucositis. Induction ensures the drug gets in.
And finally, the fourth reason.
Reason four is response assessment. We can use EBV-DNA response to induction to guide our prognosis.
So if the levels plummet.
We know we're on the right track. If they don't, we know we have a resistant tumor. It's a great biomarker.
Let's drill down into the landmark induction trials. The big one recently is the Zhang trial using GemCis.
This is practice changing in Category 1. The Zhang trial, published in NEJM 2019 and updated in JCO 2022, enrolled 480 patients.
All advanced stage?
All stage 3 to 4 BNPC, all WHO type 3. They compared induction gemcitabine and cisplatin followed by chemoradiation versus chemoradiation alone.
What was the regimen specifically?
Gemcitabine 1,000 milligrams per meter squared on days 1 and 8, plus cisplatin 80 milligrams per meter squared on day 1.
And then that was every 3 weeks.
Every 3 weeks for 3 cycles.
And the results?
In the final analysis, 5-year overall survival improved from approximately 79% to 88%.
Wow.
That is a hazard ratio of 0.51. The key is that this benefit was driven primarily by improved distant metastasis control. Local control was similar between the arms.
So if you have a patient with bulky nodes or a high risk of distant spread, this is your data.
Absolutely. And we have to talk about why GemCis is preferred over TPF.
Right. The Sun trial.
The Sun trial used TPF and showed a survival benefit too, but the toxicity neutropenia, febrile neutropenia, leukopenia was very high.
TPF is a sledgehammer.
It is. The Lai trial in JAM 2022 actually compared TPF to PF and found TPF was better if you're using fluorosil, but
But the consensus now.
the consensus now is that Gemsys is preferred over PPF. It doesn't require a 5FU infusion pump, it has better tolerability, and the overall survival data is rock solid.
Okay, let's pivot to the adjuvant question. We said INT-009, 9 used adjuvant, but we also said completion is hard. What's the modern data on adjuvant therapy?
The key trial here is the CHEN trial, published in Lancet Oncology 2012. They looked at chemoradiation with or without adjuvant cisplatin and 5FU.
And the result?
No significant difference in failure-free survival.
That seems contradictory to the meta-analysis, which showed a benefit for concurrent plus adjuvant.
It is complicated. The CHEN trial had issues. They used weekly cisplatin during the concurrent phase, not high dose.
Okay.
20% of patients never even started the adjuvant phase,
Wow.
and over 50% didn't complete the concurrent phase. It just highlights the reality of the completion problem.
Right. Patients are malnourished and deconditioned after 7 weeks of radiation. Starting intensive chemo, then, is a tall order.
It's a huge ask.
So, while the MAC-NPC pooled analysis says adjuvant adds survival benefit, the randomized data from CHEN is mixed, and practically you might not get the drug into the patient.
Exactly. That is why for high-risk cases where I absolutely want to ensure systemic coverage, I lean toward induction. I know I can get the chemo in before the radiation toxicity hits.
What about sequencing? Does the order matter if you're definitely giving both?
The NPC-0501 trial looked at this. They compared induction followed by concurrent versus concurrent followed by adjuvant. They found no significant difference in survival outcomes. Both are acceptable.
Interesting.
Interestingly, that trial also looked at accelerated fractionation and found it provided no benefit, only toxicity.
So don't do that.
Please don't do that.
Now let's get into the weeds of the concurrent chemotherapy itself. We have the high dose versus weekly debate.
The standard remains high-dose cisplatin, 100 milligrams per meter squared on days 1, 22, and 43.
The INT-0099 regimen.
Correct. It requires aggressive hydration and animetics. The alternative is weekly cisplatin at 40 milligrams per meter squared.
Is weekly just as good?
The Lee 2016 study showed similar efficacy. The toxicity profile is different. Less severe nausea and vomiting with weekly, but potentially more cumulative myelosuppression if you aren't careful.
A valid option, then.
It is, but the big concept residents need to know here is the cumulative dose target.
The magic number is 200, right?
Right. Retrospective data from Lee, Lung, and RTOG analyses suggest that a cumulative cisplatin dose of greater than or equal to 200 milligrams per meter squared is associated with clinical benefit.
So that is 2 cycles of high dose or 5 weeks of weekly.
Correct. But, and this is a big but, this is a practical target, not a hard rule.
Especially if the patient received induction.
Exactly. If you gave 3 cycles of Gemsys induction, the imperative to hit exactly 200 during the concurrent phase might be different than if you're doing concurrent alone.
I want to pause on this because it's a huge practical point. You have a patient who got induction. Now they're in week 7 of radiation. They've received 200 milligrams of cisplatin concurrently, but their creatinine is creeping up and they have tinnitus. Do you force that last dose?
No. Do not force a third high-dose cycle if the patient is in renal failure or has significant hearing loss just to hit a number.
So you treat the patient, not the number.
Yeah. You have to. Document the toxicity, document the total dose, and consider the fact that he already had 3 cycles of induction Gemsys.
Ugh.
The benefit of pushing that last 50 milligrams versus the risk of permanent dialysis, it's not worth it.
That is a great clinical pearl. Now, not every NPC is high risk. Can we ever de-escalate?
Yes, and this is very important for quality of life. The TANG-JAMA 2022 trial looked at low-risk NPC. They compared IMRT alone versus chemoradiation.
Who qualifies as low risk here? The criteria are strict.
They are very strict. You must meet all of these, stage 2 or T3 and 0.
Okay.
All lymph nodes must be less than 3 centimeters. No level 4 or 5B involvement. No extranodal extension or ENE.
And the biomarker.
And pretreatment plasma, EBV-DNA, must be less than 4,000 copies per milliliter.
And if they meet all that.
And IMRT alone was not inferior to chemoradiation. 3-year overall survival was identical, around 98%.
But the toxicity.
Was significantly lower than the radiation. Yeah. Only armed 17% versus 46%, and quality of life was much better.
So we can spare these patients the toxicity of cisplatin. That is huge.
It is. Just remember, this applies to the endemic EBV positive population they studied.
Let's zoom out and build a decision framework, a risk ladder, if you will. I'll give you the scenario, you give me the treatment.
Let's do it.
Scenario 1, stage 2 or T3, N0, meeting all the Tang low-risk criteria.
IMRT alone.
Scenario 2, stage 2, but not meeting low-risk criteria. Maybe a node is 3.5 centimeters.
Concurrent chemoradiation with cisplatin.
Scenario 3, stage 3 with low nodal burden, say N0 or N1.
Concurrent chemoradiation plus or minus adjuvant or our induction followed by concurrent. Both are acceptable.
How do you choose?
I would let patient factors and EBV load guide me. If EBV is very high, I might lean toward induction.
Scenario 4, stage 3 to 4A with bulky N2 to N3 disease or very high EBV DNA.
This is the induction sweet spot. Induction gem-cis for 3 cycles, followed by concurrent chemoradiation. Preferred because of the Zhang data on distant control.
Okay. Scenario 5, patient is cisplatin ineligible.
Carboplatin-based regimen, the Chemotherapy trial showed similar efficacy, though different toxicity, more thrombocytopenia.
Perfect. That is a solid algorithm. Before we go back to our case, are there any emerging therapies we should watch?
Immunotherapy is knocking on the door. The Continuum trial, published in Lancet 2024, looked at adding the PD-1 inhibitor sintilimab to standard induction and chemoradiation.
And what did they see?
They saw a significant event-free survival benefit with a hazard ratio of 0.59.
That's impressive.
It is. Also, NRGHN001 is ongoing, testing biomarker-guided adjuvant therapy based on post-treatment EBVDNA levels.
So adapting intensity based on response.
Exactly. That represents the future. If your EBV clears, maybe you observe. If it doesn't, maybe you escalate.
Let's bring this all back to our 48-year-old patient. T3N2M0, bulky nodes. EBVDNA is 25,000. What is your final call?
My final recommendation is induction gem-cis for 3 cycles followed by CCRT.
Walk us through the why one last time.
1. High distant metastasis risk. He has bulky N2 disease and a very high EBV load.
2.
The Zhang trial directly applies to him and showed a survival benefit. 3. Induction specifically targets that distant risk with a hazard ratio of 0.63.
And 4.
And 4. Practicality. I want to get the systemic therapy in while he is strong. I will also monitor his EBV kinetics during induction to see if he's responding.
And for the toxicity management, what are you warning him about?
During induction with gem-cis, I'm watching for myelosuppression, neutropenia, and thrombocytopenia.
So checking CBC.
Before each cycle, yes.
Yeah.
For the concurrent phase with cisplatin, it's nephrotoxicity, ototoxicity, and severe nausea.
So aggressive hydration, audiometry.
Exactly. And of course with radiation, mucositis, and weight loss.
And regarding the cisplatin dose?
I'm aiming for a cumulative dose of 200 milligrams per meter squared during the concurrent phase. But since he's getting induction, if he hits toxicity, I will not force a 3rd cycle just to hit a number.
You'll document it and move on?
I will document the total dose, consider the fact that he already had 3 cycles of induction gem-cis.
Excellent. Now let's switch gears to the board review section. We need to prepare our listeners for the oral boards. What are the common traps examiners set?
Trap number 1 is the adjuvant always trap. An examiner asks for your standard recommendation, and you robotically say, I always give adjuvant per INT0099.
Why is that a trap?
Because it ignores the mixed evidence from Chen 2012 and the reality of poor completion rates.
So you need to show nuance.
Show nuance. Acknowledge INT0099, but explain that for high-risk cases, you favor induction to ensure drug delivery. Don't be a robot.
Okay, trap number 2.
The induction doesn't work trap. They might challenge you by citing paradigm or decide.
Dr. Smith, induction failed in head and neck cancer. Why are you using it?
Exactly. The trap is to back down. The right answer is to differentiate NPC biology.
So you cite MAC-NPC.
Cite the MAC-NPC meta-analysis showing specific distant metastasis benefit and the Zhang trial data. NPC is not the oropharynx.
And trap number 3.
The cisplatin threshold trap. They give you a patient with toxicity after 2 cycles, cumulative 200 milligrams per meter squared, and ask if you should give the 3rd.
And if you say pushed through, you fail safety.
Yes. The answer is that 200 is a practical therapeutic threshold. If they have toxicity, do not cause permanent harm, especially renal or hearing damage. Document, counsel, and surveil.
High yield. Let's summarize with some clinical pearls.
Pearl 1. INT0099 established CCRT with a massive 31% survival benefit.
Pearl 2.
In the MAC-NPC hierarchy, concurrent plus adjuvant is best for overall survival and pooled data, but induction plus concurrent is best for distant control.
Pearl 3.
GemCis induction per Zhang is Category 1 for Stage 3 to 4A, specifically improving survival via distant control.
Pearl 4.
The 200 milligrams per meter squared cisplatin target is practical, not absolute.
Pearl 5.
Routine adjuvant has mixed evidence and poor completion.
And 6.
Low-risk patients meeting TANG criteria can be treated with IMRT alone.
Now let's do a board blitz. I'll ask the question, you give the answer and the rationale. Ready?
Ready.
Question 1. A 52-year-old woman with Stage 3 NPC completes CCRT, but received only 2 cycles of concurrent cisplatin, totaling 200 milligrams per meter squared, due to renal toxicity. Her post-treatment plasma EBVDNA is undetectable. What is the next step? Observation. B, adjuvant cisplatin and 5-FUC adjuvant gemcitabine and paclitaxel. D, reirradiation boost.
The answer is A, observation. She reached the practical threshold of 200 milligrams per meter squared, and she has a favorable biomarker undetectable EDV.
So adding adjuvant is just toxicity with uncertain benefit.
Exactly, especially given her renal issues.
Yeah.
The NRG-HN001 trial is actually investigating observation for this exact group.
Question 2. A 45-year-old man has T4N3M0 NPC with plasma EBDNA of 45,000 copies per milliliter. Which approach has the strongest evidence for distant control? ACCRT alone, BCCRT followed by adjuvant, C induction GemCis followed by CRTD, concurrent cetuximab.
Answer is C, induction GemCis followed by CCRT.
And the rationale.
MAC-NPC shows induction has the best hazard ratio for distant metastasis at 0.63. This patient has extremely high distant risk due to M3 status and high EBV. And cetuximab is not standard for NPC.
Okay, question 3. Which statement about INT00999 is true you? A, enrolled primarily WHO type 3.
B.
E, over 90% completed adjuvant. C, stopped early due to survival benefit. D, used weekly cisplatin.
Answer is C. It was stopped early due to a 30% survival advantage.
And the others are false because
A is false. Only 41% were WHO type 3. B is false. Completion was terrible, around 55%. And D is false. It used high-dose cisplatin every 3 weeks.
outstanding. This has been a comprehensive look at the systemic therapy backbone for NPC.
It really is a unique disease site. Just remember, while INT0099 is the foundation, the modern standard for high-risk disease is moving toward induction to secure that distant control.
Next time, on episode 24, we will cover response assessment and salvage. We'll talk about imaging timing, EBV kinetics, and the scary world of reirradiation and carotid blowouts. You won't want to miss it.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.